Lydia. We're here to solve life's next chapter problems again, or just all the good things that happens about getting older as well. Right. But today we're here with our friends Lori Gudino and Kerrie Commiskey. Both are from Santé, and we're going to talk a little bit about the difficulty in keeping people out of the hospital. So once someone has an injury or are ill and they are discharged, all of us, and Neighbors Who Care is actually part of this as well, because we interact so much with our clients. So folks, and many of our clients are in their elder years, their 80s or even 90s. We actually have several clients who are over 100. But one of the things that our volunteers does is helps them once they are discharged. Right. And the groceries that we help them get, the meals that we deliver to them, and trips to therapy appointments helps keep them out of the hospital once they get home. And so that's something we're really proud of. Right. We work closely with a lot of medical facilities that...
and everybody wants to be home.
Absolutely.
I mean, who doesn't want to be home?
And so that is really one of the big things that Santé focuses on as well, right?
Yes.
Tell us a little bit about what that looks like and what that what those kind of functions are that you work on to help people be healthier, so when they leave your facility, they don't end up back in the hospital.
So I think, probably all of us have had an experience where we've had to go to the ER and we're in the hospital, and right, it's a long experience. I mean, our hospitals do a great job. We have great hospitals in our community, but it's just, it's an industry where your customers don't want your product, right? Nobody says, oh my God, I'd really love to go to the hospital. Except when I had my child, I wanted to stay there forever. I was not ready to leave, but
that's the only time.
But besides that, so it's so important. And this is something, that we are really passionately about, not only, from our rehab centers at Santé, but our continuum, which I'll let, Kerrie speak to in a little bit, but from admission, we're looking at and tracking our guests every day, trying to avoid those readmissions. It's big for us not to have readmissions. I know the hospitals feel passionately about that. They're constantly looking at and reviewing. So it's so important to be looking at, not only our guests every single day and how they're doing, but if we do have a readmission, breaking down, okay, what happened? Meeting with our medical director, going through saying, was there anything preventable that could have been done? Right. Again, because the intent is, keeping people out of the hospital, keeping them healthy and well to the best of their ability and getting them back home. So.
Right. And I know that, when you think about it, you say, well, no one wants to be in the hospital, right? But if you've ever had a catastrophic injury of any kind, it's hard to get better.
It is.
It's a lot of work.
It is a lot of work.
So I relied on the folks who were caring for me when I had an accident to tell me, you want to get stronger. This hurts, or this isn't
want that
fun.
Encouragement.
But yes, and I'm sure that is one big part of what your folks do there, your therapists and the work with the patients to make sure that they get better, because sometimes it's hard. You don't want to do the work.
Right. And sometimes you focus on, the pain or some of the setbacks that you've had instead of what this can look like as you move forward.
Or what you used to be able to do and now you can't do it anymore,
Absolutely.
So
we have a team. I mean, we have not only the nurses, the skilled therapists, we also have case managers, we also have social workers. We have a whole team of people, we call it our interdisciplinary team, that's working with our guest to ensure that they have what they need. So whether
they all communicate with each other about that patient as well.
Yeah.
Right.
We have they're communicating with each other. We have routine meetings every single day, but then we also have very concentrated meetings once a week that we call our interdisciplinary team meeting, where we're discussing every guest that we care for and what the plan is and how they're moving through and progressing in their therapy and their skilled nursing.
Do some of the patients or your guests, do they get a choice on some of those, when you're putting a plan together for them? Because ultimately you want them to go home, and you have a home health care company as well that helps them through that. Mm-hmm. But are they part of that process when you're trying to work on putting a program together to get them out of your community and back into a home setting?
Yes.
Are they part of that process?
Yes, and patients always have choice. They have choice when they're in the hospital, making that next step and move. Some folks will refuse and just say, I'm going home.
Okay.
Right. We have folks who have been with us for a few weeks with therapy, and sometimes they don't necessarily want someone coming into their home.
Okay.
So we'll explain to them the benefit and what that looks
Right.
like. And again, oftentimes it might mirror what's been happening in one of our communities. And so you're still going to have a nurse that's going to show up to maybe treat that, care for the wound that you have.
Right.
And then the therapist will come out. Now, obviously, they're not going to be there 24 hours a day.
Right.
And they're not going to be there every day.
Right.
It's a lot more, it's abbreviated, it's intermittent
Right.
once they return home. But typically within the first 24 to 48 hours after one of our guests returns home, we do what we call our start of care. And that's
Okay.
either initiated by an RN, so a skilled nurse,
Okay.
or a physical therapist. And so they go out, they assess the patient, and then we get our plan together to start the care for that home health episode.
Gotcha.
So when the patient admits to the rehab facility as well, our part of their intake evaluation is asking what's your home environment, very detailed questions about what their day-to-day looks like.
Okay.
And then they will state at that time, on board with plan at this time, to be continued, or concerns at this time. But so it's a constant kind of check-in based on the progress. And obviously this is a therapy level. There's a therapy aspect, there's a nursing aspect, right?
Right.
Two different, very different things.
Right.
But that's where the combination of the teams and the communication with the teams on that. And so, weekly, these are daily, they're discussed, but weekly we have a collective interdisciplinary specific meeting on discharges. So if anyone ever had questions where they stood, they just have to, if they haven't already gotten that information
Right.
immediately, just ask, because that should be documented.
Right.
Because these facilities should be planning discharge from day one as far as
Right.
setting them up
We
for
hope so.
success.
Right. That's the goal, right?
And what Lori's saying is we really do that deep dive and think about some of the barriers to success. If you've had something catastrophic happen, if you live in a single level home,
Right.
it's much different than living in a multi-story home.
Right.
Even just to get into your house, are there steps to get into your home,
Right.
or do you just take one step to get in your home? Those are all obstacles
Right.
that we have to be thinking about while they're working with us in our community before they return home.
And then once your home health care gets involved, they go and kind of assess the home as well with them to see
Absolutely.
what some of the programs are that you can offer them for people maybe that have a tri-level home that maybe doesn't have a bedroom downstairs. And
Correct.
maybe you can put a makeshift bedroom downstairs until they get healthier to be able to go up and down the stairs.
Absolutely.
Okay.
To safely and successfully do both, right? To be able
Right.
to go up and down the steps. And
Right.
absolutely. And they have benefits oftentimes for not only those therapies, but sometimes what we call DME, or durable medical equipment, to be brought into the house.
Okay.
So whether it's the walker, the wheelchair, maybe it's a hospital bed,
Right.
all that equipment can be set up in the house to help them as they also continue to rehab.
So let's talk about the individual who may be aging or may have had a situation where they are not improving at a quick rate, or their age is in the way, or perhaps their condition is diminishing, and they're receiving the same kind of care that they did a year ago, but now they're a year older, and maybe their care is changing, and their condition is changing. What does that look like?
Well, every case is very different,
course.
typically. But what I mean by that is that sometimes people are more open to conversations about, okay, this is, where we stand. This is our recommendation. It's different than where your home environment was prior.
Right.
So oftentimes, because, it's a difficult conversation to have, these are done in kind of care conference formats. They can, people can have conversations in the moment, but if there's families involved, different players, ultimately the patient is there, often people will say, I'm the power of attorney. Okay,
Right.
but is your loved one, they're not incapacitated. So
Right.
that's not
Yep.
in effect yet.
Right.
So many people misunderstand
they do.
powers of attorney.
Yes. We're happy to include anyone that our guest wants to be
Right.
included.
Sure.
So it's not with that, but we have to respect ultimately the guest
Right.
is there. What do they want? That's the
Right.
key. And sometimes they're agreeable with the plan, and sometimes they're not. And sometimes we have to
Right.
discharge individuals in situations where we may not agree with from a safety perspective.
Right.
But if they're alert and oriented, able to make those decisions, those are their decisions to be made.
Yeah.
When might a conversation about hospice care enter the picture? When might that happen?
like you were mentioning earlier, right? We might be seeing a guest a year later, right? They've been at home successfully for a year. Something occurred that put them back in the hospital. Now they're back with us in our community, and there's been a significant decline. If we see that significant decline, oftentimes we're thinking and working with that resident, that patient, and their family, and talking about, so what does this look like next, right? And maybe we're discovering in those conversations that they've been in and out of the hospital multiple times over the course of the last year. This is just the first time we're seeing them.
Right.
So if that's the case, we start talking about those options. Do you want to continue in this cycle of going to the hospital, going home, going to the hospital, going to a facility, going back home, going to the hospital? It's exhausting, right?
It's
and
awful.
For the person who is in their 80s or perhaps their 90s, it can be very confusing with or without dementia, right? That suddenly you're in this huge environment. There's staff that's constantly coming and going because hospitals are a really busy place.
And you're out of your environment, you're out of your routine. And
Exactly. And sometimes, unfortunately, people will make an assumption because someone is a lot older that maybe they can't hear, maybe they don't know, maybe. And so sometimes there's communication breakdown in those spells or those stays in the hospital and even in our environment, right? So we oftentimes will have that conversation. What do you really want to achieve at this point? Are you looking at quality of life,
right,
or are you looking at quantity of life?
Right.
And so, oftentimes people go, I don't know. What does that mean? Let's talk about that. Some people don't want to talk about it at all.
Right.
But for those who do want to talk about it, we can really talk about what does quality look like. If quality for you is living in your home and being successful in your home, let's talk about all the services that we can infuse to your home so that you can be successful there. And that might look like hospice services.
Right.
Hospice is a benefit that folks have earned as well under their traditional Medicare, right? And it infuses all sorts of care. And it's not necessarily about end of life. It is ultimately. We're all one day
gonna
closer,
die,
right?
Yes.
We're all gonna
One day
happen.
closer.
Yep, it's happening.
But we have folks who look at, okay, I'm on a dozen medications today. If I decide to go with hospice, we start to scrutinize those medications because maybe I'm taking 3 medications that were for an illness that I was diagnosed with 25 years ago. And it's really not an issue any longer.
Right.
So then as we start to weed through something as simple as my medication list, all of a sudden I could start to perk up because now I went from a dozen medications to 4.
Right.
And just that
It's so
alone,
true.
my quality of life has improved, right? And again, infusing services, it oftentimes with a hospice program, there's a nursing component who's coming out to visit you multiple times a week. There's a nursing assistant who's coming in to visit
Right.
with you. There's chaplain. So there's that model, the social work model, all of these folks who are working to support you and finding out what you want to do as you live your life. And that you could be living your life for another year, 2 years, who knows how long.
true.
It's not about, pulling
There should
the
be
plug.
a campaign to totally obliterate the word hospice.
Rebranding.
Rebranding. I like it.
Yeah.
Me too.
I don't know
Because
how
everybody thinks hospice is end of life, which it is in a sense. But I mean, a lot of people, the problem with hospice is they get onto it too late.
Right.
And then they pass away a short time after. So everybody's got that mentality, I'm going to go on it. And then 2
It's
days.
because they put it off.
It's because
Right.
they've
Most
put
of
it
the
off for
time.
so
People
long.
think that it causes end
Yes.
of life or
Right.
death. And
Right.
it doesn't.
It does
if you
not, no.
if you choose early enough, you can reap so many benefits. But it's also about the family, the loved ones, the caregivers.
That's for
it's
sure.
a resource for them.
Right.
And
Let's
to be
talk
able
about
to
that.
have
Let's talk about what hospice means. That term hospice. So it's a different philosophy of care that is meant, and I'm piecing this together as I go here, but it's meant to keep the person comfortable and not necessarily hasten death at all, but just make them comfortable and remove any curative measures that aren't going to make a difference in their day-to-day life.
It can, although I will tell you, for example, if somebody comes down with an illness and they need an antibiotic, for example,
Sure.
we have hospice patients who
Right.
will receive their antibiotics, right? So people even think that, like we're going to withhold
that
an
you're not
antibiotic.
going to get it. Yeah.
Yeah, and that's not, again, an antibiotic's probably going to make someone comfortable, right?
Right.
And help them recover from that illness. But a diagnosis that could be terminal, whether that's a dementia diagnosis, a cancer diagnosis, there's so many different things that could be considered terminal, doesn't necessarily mean terminal tomorrow.
Today.
Right.
And if you think about it like a benefit and not as an outcome
Right.
too, I think the understanding that this is a different benefit.
Right.
It may come with different benefits
Sure.
that might fit for where you are in that moment. So equipment might be covered, or there's different aspects of you still have
It
to qualify.
switches what you're qualified for
Exactly.
when
You
that
still
when
have
that
to-
designation happens,
And
right?
you do have the ability, again, you have choice. So you could choose hospice, and you can be, again, with all these additional, I always say touches, right? All these wonderful people
Right.
that are interacting with you. Oftentimes people do start to feel a lot better. So 30, 60, it's unlimited. You can make a choice 6 months later to say, I'm going to opt out of my hospice benefit right now and go back to my traditional plan. I'm going to resume. I'm going to pursue care, etc. You can do that. It's a
Right.
choice.
Right.
Right.
It's you. It's your body. Like
Yeah.
you're in
Absolutely.
charge of
And
you.
that's a very misunderstanding, because people think once they're on it, that's it. They're
Right.
You can say, I'd like to opt out at this point. I think I'm going to take a different approach. And
Right.
you absolutely have the right to do that.
yeah.
So I want to real quick, when Kerrie was talking about medication and the spirit of talking about readmissions, one thing I really want to advocate is medications are often one of the biggest readmission reasons.
Oh.
So anytime you change a level of care, whether it's from home, well, obviously you're home to hospital, you're
Right.
already in the hospital, from hospital to rehab center to home, whether with home health or any kind of services or not, anytime you're changing care, whatever's receiving is getting the medication list from the prior, right?
Okay.
So when we have guests who come to us, our patients who come to us,
Right.
we're getting the med list from the hospital. Well, the hospital was maybe treating an acute scenario. So maybe there's some long-term medications that weren't on that hospital list.
Okay.
And that's a big
Oh, like a I don't know, blood thinner or
Right.
something like
Yeah,
that.
something.
Right.
Okay.
So, not saying that hospitals don't do a good job of reviewing,
Right.
but anytime we're changing those, there's a potential that something gets
Right.
missed. And this is a common thing we hear. We hear family members or
That happens
patients
a lot.
who find out, days later, even though we provide the med list, oh, well, why wasn't my loved one on this medication? They're very upset. So, they're in our care. That's a little more structured and,
Sure.
Right.
we're tracking them. So if you go to a rehab center, review the medications,
That's
make sure they're accurate. But then when you go home, right, a next level of care, make sure you're reviewing the medications. Make
And
sure
are
we're
you
looking at
needing
that.
the medication that you needed when
have.
you were in your community? And that does make sense to me, because with my daughter, I have questioned her over the years on, because I hear that a lot from families. Why did my dad get off the blood pressure medicine that he was on before the hospital? And I asked my daughter that one time, because, she goes, Mom, she said, when we're working with someone in a hospital setting, it's usually a traumatic situation. And not that we're not checking their blood pressure, because they are, but the blood pressure medicine isn't as important right now as maybe something else that they're going through. So she said, and that's why the hospital always says, or the rehab always says, go back to your primary care doctor.
Right.
And if people don't go back to their primary care doctor, they don't get back put on some of the medications that they need to be put back on. And so that's probably where you come across that a lot with your communities as well.
And with all the levels of care that we offer, we see that as they transition from, as Lori said, the acute hospital setting to our skilled nursing setting, and then they return home. That's a part of what home health can do. That's a part of what our chronic care management team can do.
Yep.
We deploy higher level folks, so a nurse practitioner that goes out to the house who looks at and does we call it med reconciliation, right? So we look at your medicines, because here's what also happens. Well, I've had these medicines that I've been on previously, and I've got them sitting here at home. I go to the hospital, they work me up, they rework meds, and they might even say you should no longer take the medications you have
but
at
it's
home.
still sitting there at the
And I paid for it, which is oftentimes one of the finer points for folks. They're with us, they go home, and then they say, I'm going to take what I had, what they prescribed me today, but I'm also going to take this because I've been taking it.
Right.
So without that interaction with, again, a provider who says, let's look at this, let's see what's really medically necessary for you today, and then reconcile those meds and get them on a path. Because as Lori stated, what happens is people either over-medicate or they under-medicate, and they end up right back at the emergency department.
That's a great point. And that is one that's just educating families on that specific situation. I mean, I wouldn't know what, and now that I have a daughter in the hospital, I mean, I understand it now, but if I were to just go into the hospital and say, why am I not taking my blood pressure medicine anymore? You know, it's just one of those things that people don't know what they don't know. So education is a huge part of it. So your home health care or home health care in general can help facilitate, okay, let's get rid of these medications because you're no longer needing them, but let's add these medications and we'll do it this way. So that's
what did you call that meeting where they talk about the medications? With
med.
The med
Yeah,
reconciliation.
that's it.
Yes.
Yeah, I like that.
I like that too.
Yeah.
And I really hope that the more of us talking about this, as we have so many of these baby boomers turning 65, we talk about this all the time.
12,000 people are turning 65 every day
The
in
silver
2024.
Yes, we do talk about the silver tsunami as well. But maybe the more we talk about things like medicine, what is it called?
Reconciliation.
Yes. I don't know why I can't think of it. And hospice, defining it and talking about it, that more people will start being better advocates for themselves, or maybe their children who are my age can be better advocates for their parents, and then for themselves as they age. And because life doesn't stop for me because my 84-year-old mother's getting older. You know, it just doesn't happen. So I really appreciate the information because I think we can't talk about it enough.
I agree with that.
Yeah. So, well, thank you both again. Did you want to add anything about this topic of recidivism and hospice care? I think we covered a good swath of information.
I think so. Yeah.
Great.
We appreciate your time.
Well, thanks
once
for
again,
coming.
Lori Gudino and Kerrie Commiskey, thank you so much for joining us from Santé.
Thank you.